Hello friends, today we will go to the operation theatre to watch the live video of the laparoscopic hysterectomy with appendectomy. And this is a very interesting case. I hope you will enjoy it. So let us go to the operation theatre. Here first we will do cystoscopy. The purpose of doing cystoscopy is just to introduce the fiber optic ureteric catheter so that we can illuminate with the infrared the ureteric catheter. Now this hysteroscope is introduced into the cystoscope. Actually it is cystoscopy which we are using with the hysteroscopic sheath so that it will be very nicely visible, and advantage of stenting with the hysteroscopic sheath is that you can introduce the guide wire directly into the ureteric orifice and it will give you beautiful vision, and the guide wire also goes in the balanced manner. So this is now inside the urethra, now this is in the bladder, and here is the ureteric orifice. This is the right ureteric orifice. You have to go with the guide wire and just aim it, and guide wire is introduced. After that, transparent 6 French ureteric catheter will be introduced. The striker is providing it by the name of U-kit, and urinary kit, that is a fiber optic ureteroscope, and now it is introduced. This is the left ureter, your right is patient left, this is the left ureter, is at least 20 centimeter it should go in. So 4 dark lines should be introduced in, that means it is 20 centimeter. Every 5 centimeter one dark line is there, so it is done on the left side. Now you will remove the cystoscope and again you can put the another stent, another catheter, transparent, and you will introduce again into the left side. So your left is patient right, and this is again it is getting loaded, and again it is entering into the urethra. So you have to do individually in both the urethra, stenting is required. So this is now it's going, and here the guide wire is introduced, soft end of the guide wire. And then this transparent ureteric catheter will also be introduced. So it is over. Now we will attach this end, we will take the guide wire out and you can introduce fiber optic. So this is fiber optic which has been introduced into the transparent ureteric stent. This fiber optic will illuminate this, and both have the individual fibers, and this fiber will be attached. This end of the fiber will be attached with the light source, and in the striker light source, all the recent light source of a striker has a separate attachment of the infrared which you can introduce, and then you will switch on and you will press the iris mode. That is the iris mode, and now we can see it is infrared is blinking, and now it is done. So cystoscopy part is over. After that we will start now laparoscopy. So this is a patient with the menorrhagia and medical therapy has failed, so now we will do the total laparoscopic hysterectomy, which is advised by the gynecologist, and we always have a gynecologist in our team. This is inferior crease of umbilicus, that is for 18 mm, but because of bulky uterus we will put supraumbilical. So this is 18 centimeter, that is from the target, and this is the 7.5 centimeter lateral. This is the right hand port, and again 7.5 centimeter lateral. This is the left hand port. So we have 2 ipsilateral port, and then mirror image of the left lower one. This is the arc, this arc is at 18 centimeter. and the target is the UV fold, that will be the umbilical artery, and this will make a shape of a baseball. And another arc of the baseball is at 24 centimeter. So one is 18, this is 18 centimeter, and this is 24 centimeter. So here we are planning to put the telescope in 24 centimeter. This is 18 and this is 24. This is umbilicus and this is supraumbilical. So telescope will go supraumbilical, and 2 ipsilateral port and 1 contralateral port. This is the planning for this surgery. So now you can start introducing the varus needle, and we will use 4 port technique, 1 for telescope, 3 for working instrument. One small stab wound will be given over the inferior crease of umbilicus. After that you can introduce the varus needle by lifting it and perpendicular to the abdominal wall but oblique to the body, and 2 click sound you will get it. After that you can take a syringe and you can do the irrigation test. Now suction test, and then this is hanging drop test, and once you lift the abdominal wall it is sucked in. Now we can attach the insufflator and you will wait for pneumoperitoneum to be achieved. Here we can see the blinking of the infrared, and this is the insufflator. Insufflator is right now slowly increasing the pressure. Preset pressure is 15. Actual pressure is right now 9. We have to wait till it become 15. And we will use ligation. On the top you can see ligation. Below is the insufflator. Right side is a light source with infrared blinking, which you can see. So now actual pressure is 13. And then 15. Now we will enlarge the incision to 11 mm and the trocar will be introduced, holding like pistol, and it will be introduced. After that telescope is in, and these are the 2 other ipsilateral port which will be introduced. Now all the ports are in the position. Now 1 contralateral port also will be introduced. And once all the port is introduced, then you do the diagnostic, and then uterine manipulator will be introduced. So our gynecologist is introducing here the uterine manipulator, and this is a tenaculum, and here first you have to dilate with the 5 number of Hager dilator, and then you can use the uterine manipulator. Here we are using full circle uterine manipulator with tenaculum, and you can bite the anterior and posterior cervix with the tenaculum, and uterine manipulator will be introduced. Now by the meantime you can do diagnostic laparoscopy. This patient has follicle rupture, so some blood is because of follicular blood, and then this is the uterus. Uterine manipulator will push the uterus towards the opposite shoulder. Like here we will start right side dissection first, so uterus will be pushed towards the left shoulder, and now you can start your dissection. 4 centimeter lateral to the round ligament. Here we can see ureter is nicely visible due to the ureteric stent. This is the entire ureter is visible, and if you will move the fiber optic you can make it more up. So here we can see that fiber is not illuminating, so you can push the guide wire further and it will see now it is coming up, and this fiber is completely going up, and this is a beautiful vision which you have in the transparent ureteric stent. Now this is the 4 centimeter 2 and 2 4 centimeter lateral. Now you can take the round ligament, and this is round ligament which we will coagulate it first. After that you can get the fallopian tube. In this patient we are planning to keep the ovary intact, so this is fallopian tube which you will take, and then you can take mesosalpinx and round ligament together. After that this is the ovarian ligament, and this ovarian ligament will be approximately 2 centimeter lateral to the uterus, and here is the mesosalpinx and mesoovarian together. So now you can go left side, and again the uterus will be contralateral traction. Again 2 and 2, 4 centimeter lateral. So this is round ligament is cooked. Now this is fallopian tube together with the mesosalpinx. This is ovary, so ovary has to be held, and then you can take ovarian ligament. Now you can go 2.5 centimeter over the broad ligament. Again another side also we have not completed 2.5, so that also you can do. And it is done. After that uterus will be at 5 o'clock position. You have to put the uterus completely retroverted. Left hand will stretch the anterior leaf of the broad ligament. And with the right hand you can keep on opening the anterior leaf. Once you will separate the layers, ureter will drop down, it will go lateral. Assistant will move the uterus. From 5 o'clock it will go 6 o'clock, then 7 o'clock, and slowly you can separate the peritoneum. Now the uterus is at 7 o'clock position, and the right side of the anterior leaf of the broad ligament is opened, and it is widely separated. The bladder also will be separated. You should see the crisscross pattern of the vessel over the vagina, and with the blunt separation you can push the bladder up. In this patient there is no much bladder, but in some of the patient where you have cesarean, you need to separate it nicely. So it is anterior leaf is done, and this way you can separate the bladder period also away, and that is the thing which will help you to prevent the ureteric injury. So now you will put the uterus anteverted at 2 o'clock position, and you can start separating the posterior peritoneum. As you will progress, assistant will slowly do the uterus at 12 o'clock position. This is the uterosacral ligament. So generally we take the peritoneum above the uterosacral ligament and separate it. Here you can see the vascular pedicle. This is uterine vein which is visible, and ureteric stent is illuminating nicely. Then you can go to the other side. And at this time uterus is at 2 o'clock position. And you can open the posterior peritoneum of this side also, taking care that artery should not be knocked. Tip of the harmonic sometime can knock the artery. This is the vascular pedicle of the right side, and the entire posterior peritoneum above the arc of uterosacral ligament is open. So now it is over. If you have a little oozing, you can just touch with the tip of harmonic. Now we will start uterine artery coagulation. So first couple of coagulation should be done on the ascending branches, and then go to the uterine and you will coagulate. So you can coagulate 2 times. And generally first time when we coagulate, we don't cut, and then go to opposite side and again coagulate the opposite side. This is the time you should take the ligation on the same side of the port. That is one of the need of the contralateral port. So this is 1 or 2 times coagulated. After that you can come back again to the left side, and this time final coagulation and cutting should be done. So this is final coagulation, and then you can cut it, and again other side final coagulation and cutting. As we know, with the ligation you have a blade. With this blade you can cut it. So this is right side. This is coagulated final. And then cut. So now it is done. After that you can go little posterior, because sometime the vein may remain uncooked, which may bleed, and you can coagulate and cut once more. So it is over. Then you can start doing the colpotomy. We can see the color of uterus is completely changed. That means uterine artery is secured. Here you can take the harmonic, and with the vibrating tip of the harmonic it can start doing colpotomy. Maca and rod will cut, and after that vagina will be cut at the tip of the colpotomizer. Assistant should stretch the vagina by pushing it in so that you can easily separate it. This is bladder. Bladder is in the position. Then you can keep on cutting. So complete half circle should be cut from the one side, and other half of the circle should cut from other side. But generally we do more from the left side because you are standing on the left. So it is done. Now you will go for the posterior. So uterus will be lifted up, and then you can start doing the posterior colpotomy, taking care that uterosacral should not be cut completely. Only the cervical part of uterosacral will cut. Vaginal part of uterosacral will remain intact. Assistant can help you by supporting the uterus, and then you can start the colpotomy posteriorly. Slowly it is continued over the tip of the colpotomizer. If you don't have a harmonic, you may use the hook also, or a spatula, or some people they use scissors with the monopolar. So this is over. Now little bit remaining part you can do from right side. So this is done. Now harmonic will be changed and it will be taken on the right side. And then you can cut the remaining right part. So it is over. Now it will be taken out and uterus will be removed through the vagina. After that, we will do here bilateral salpingectomy also, because this patient tube also, ovary we will leave it and tube we will only remove. So now removal of the tube is very easy. Anteromedial traction has to be given and you can cut it. Assistant will put one stone holding forceps through the vagina and then you can give him this tube once you want. Now you can keep it. We will give the tube together. And this is other side of the tube will be removed. So it is done. Now you can transfer it to the stone holding forceps which has been introduced through the vagina, and both of them simultaneously assistant can pull out. Now assistant will give you the needle, and needle can be introduced through the vagina itself. We can see here needle is coming with the suture and you can catch it and then you can start doing the suturing. Here we will use the intracorporeal suturing, and you can hold the posterior vagina and taking the corners with the uterosacral ligament also, you can start suturing it. So this is the needle. Here is the gloves. You can see the gloves which is packing the vagina. And now you can use Maryland or grasper and then keep on taking the bite. This is posterior vagina. Support the bladder or ask the assistant to lift it is better. If assistant can hold the peritoneum and stretch it up, then you have little easy to hold the anterior vault, and then you can take a bite. Care should be taken that bladder should not be pricked. And then you can keep on separating it. Now we will continue it. It will be two layer suturing. So one we will continue continuous, and then again we will come back to do the another. Left hand can hold the suture. That will make your easy suturing because it can retract. Now you can go to the other corner. One by one is better. Sometime needle start getting rotated. So in those situations you can pull the tail to make it straight and take the bite. This is posterior vagina. And then again separately anterior will be taken. First time when you go, you should take one by one, that is better. And now in the corner, you can lock it. After that, you can return back. And then it is also locked. And then with the tail, starting tail, you can terminate. Although here we have planned to take one more bite on the right side. There is one out poaching, so we tried that, take one more bite and then terminate. So you can make a she and then two wrap will be taken. This is ipsilateral suturing. Then hold the tail and first time double wrap and it is tightened. After that you can make a reverse C. Then again it is tightened. Now you can take one more C. And this is final suturing. Here in the closure of the valve, this is your choice. We use extracorporeal square knot also. We can use continuous intracorporeal also. You can use barb suture also. You can use the dandy jamming knot also, and sometime western knot also. So this is now done, and that needle will be taken out with the 5 millimeter port. So assistant is holding the tail to trim the tail. You can cut it, and then it will be removed. So it is over. Now we are planning to do appendectomy also in this case, because she has previously some issue with the appendix. Now it is very simple surgery, just you can hold it and start dissecting with the harmonic. So this is retrocecal appendix. Major appendix is behind, so we will start from that area, and slowly you can separate the major appendix. Cecum and tinea coli we can see little torted, but once you will take little major appendix, then torsion will be corrected now. Now it will be all right, and then you can separate. You have to be careful when you are taking posterior. That should be careful. So now this is major appendix, and appendicular artery will be there, which you can cook, and now it is separated. So we will use the extracorporeal knot, that is extracorporeal Mishra's knot, which you can bring it and introduce the grasper into the loop, and then you can take it out. After that, keep the knot pusher over the junction, and then you can tight it securely. You can see throughout the procedure this ureter is looking very interesting. It is illuminating. This is now tightened. One knot is more than sufficient, as we know that Mishra knot is good enough up to 18 millimeter diameter of the structure. Tail also will be trimmed, and now you can use harmonic or ligature to just cut the appendix. We will not tie the second or third port. Directly with the harmonic it will be transected. The advantage is mucosa also burned, and appendicular side will seal. So it is over. Now this suture also is removed. You can introduce, now take the 10 mm telescope out, and we will put 5 mm telescope in left iliac fossa, and appendix will be removed with the 10 mm optical port. So here this is claw forceps and pulling the appendix out through the optical port. So thank you very much for watching this video. Have a nice day.